There we go. Hello, everybody. Welcome. It is 9 o'clock right now, but I'm going to give it another minute or two to see if we can get a couple more people from the committee signed in and logged in. All right, there we go. All right, we got 9:02. Let's call this meeting to order. As chair for the Advisory Committee for Resilient Nevada, I'd like to call the meeting to order and start a roll call of members to see if we can establish a quorum.
Jessica Barlow.
Good morning, everyone. Jessica Barlow, present.
Brittany Collins Jefferson. Lenitra Grady. Ryan Gustafson. Dr. Kamyar.
Present.
Carissa Loper indicated she would not be able to attend. She's excused. Catherine Loudon. Cecilia Maria. Elyse Monroy.
Present.
Darcy Patterson.
Present.
Pauline Sala. David Sanchez.
Present. And Joan, we got maybe one or two people that have just recently joined.
I see Lenitra Grady is present.
Good morning.
Ariana Saunders is excused. Cornelius Sheehan.
Present.
Laura Sherwood. Dr. Carla Wagner.
Present.
Quinny Winbush.
Present.
And that gives you quorum. That's 9.
Thank you, Joan. We will then, since we have quorum, let's move to agenda item number 2. At this time, we'll open up for public comment number 1. Public comment can be taken during this agenda item regarding any item appearing on the agenda. In consideration of others, those who may wish to provide public comment, please avoid repetition and limit your comments to no more than 3 minutes. No action may be taken on any matter discussed under this item until the matter is included on the agenda as an item. Is there anyone from public comment that would like to speak? Looks like I have in the chat Mike Fuller. Mike Fuller, are you interested in speaking for public comment? All right, I'm going to move to the next person. Mike, if you are interested, please comment in the chat when you get a chance. I have Kimberly. I can't see Kimberly's last name. There we go. Kimberly Sarandos. You have public comment? Joan, can we confirm that those wishing to speak on public comment have an opportunity to speak?
Hi, can you guys hear me? This is Kimberly.
There we go, Kimberly. I have you now.
Hi, thank you. So good morning. My name is Kimberly Sarandos, Program Manager for Join Together Northern Nevada. Our work as the Prevention Coalition in Washoe County is foundational to prevention efforts in our community, and we found the Mercer Needs Assessment to include several areas of oversight. This committee should note that there are 10 prevention coalitions in Nevada that serve all counties and are recognized by state statute. They are not drawn upon or indicated directly in the needs assessment. Due to the time limit, I will only be referring to page 38 of the Mercer draft document, subheading Education in Schools, as it specifically cites Washoe County prevention efforts. The Healthier Nevada Youth Education modules mentioned in the noted section is not accepted as evidence-based by the federal or state government and is not currently, to our knowledge, implemented in Washoe County School District. This example states that this education occurred in 2017 and therefore it's not current. The prevention information in this document is incongruent with what we know to be true and urge you to consider these inconsistencies in your decision-making process. The following is a list, albeit not comprehensive, of evidence-based prevention programs that JTNN either implements directly or funds within the district. Positive Action, Big Brothers Big Sisters Mentoring, Sports Prevention Plus Wellness, Botvin Life Skills, Catch My Breath, Super Parent Supervised, Tall Cop, and NIDA Mind Matters. The word coalitions is only mentioned a total of 4 times in the document, which is notable considering the breadth of services the coalitions offer. The rejection of the coalition information and material is misleading as it suggests there's very little prevention work in the state. This couldn't be further from the truth. We include certified prevention specialists, community health workers, and community partners ranging from government entities, law enforcement, mental health professionals, community members, and sectors as defined by drug-free communities. We complete comprehensive community prevention plans, which examine local level risk and protective factors, the very needs assessment sought by Mercer. We know our communities. Again, we urge you to consider the data-informed, evidence-based prevention JTNN and other coalitions engage in as you process this assessment. Thank you so much for your time.
Thank you, Kimberly. Next up for public comment, I have Jamie Ross.
Good morning. Can everyone hear me?
Yes, Jamie, we have you.
Thank you. Good morning. My name is Jamie Ross, Jamieross. I'm the Executive Director of the Pact Coalition in Las Vegas. 2 things I'd like to mention. I do not believe that primary prevention or preventing substance use disorder from occurring in the first place. Excuse me, sorry, my document just disappeared. Is focused on enough in this document to appropriately address the issue. On page 28, prevention programming begins. And the first mention is of 0.05 treatment, which by its name is not focusing on preventing substance use disorder. It is treating the disorder. Most prevention mentioned in this section is overdose prevention, homelessness prevention, but not actually preventing substance use before it begins. There's a wonderful system in place that JTNN has just mentioned where schools collaborate with prevention coalitions in every county statewide for evidence-based prevention programs in schools. These programs, as they are not one size fits all, it is not a program, but many, many different programs fit perfectly within the priority 3 in the Johns Hopkins document focusing on youth prevention. In section 6 of this document, best practices, beginning on page 51, I was worried that the most upstream solution in the Johns Hopkins best practices was working with the Prescription Drug Monitoring Program, or PDMP, and there was no primary prevention in their best practices. I'm lucky enough to be currently in Atlanta at the RX Summit, and I was able to listen in to a session about the distribution of these dollars, which I understand that this document will inform the decision, and as well as best practices. Dr. Josh Sharfstein and Sarah Whaley from Johns Hopkins spoke on this topic. Josh actually helped write the 2021 document, Principles for the Use of Opioid Litigation Funds, which is the guiding document Nevada chose to follow. I was able to ask Dr. Sharfstein why the 10 best practices did not have any primary prevention, and his response was, wasn't that written in 2017? When I affirmed that yes, it was written in 2017, and that was what our state was utilizing, he said, your state should be utilizing the document written in 2021, as it is the document written for this purpose, and of course is much more up to date. So I would encourage you all on this board, as well as Mercer, when finalizing this document, to defer to the experts and continue to only utilize best practices that are current and include primary prevention in many more ways that it has currently been written into this document. I refer you again to Principle 3, Investing in Youth Prevention. As a side note, Dr. Sharfstein and Sarah Whaley, who worked on this, the Johns Hopkins Guiding Principles document, we're both interested in collaborating with Nevada, and I am happy to connect you with those experts. Thank you.
Thank you, Jamie. Next, I would like to call on Katrie Saunders.
Hi, Grand Rising, everyone. This is Katrie Saunders for the record, Katree, last name Saunders. Hope everyone is doing well today. I just wanted to know if I had input on recommendations that I would like to see, where would I forward those to? And also, me being a patient advocate with Last Prisoners Project and Americans for Safe Access, I can also forward over some information that would be useful moving forward. Thank you for your time today.
Thank you, Katrie. Katrie, I will get a answer to you in the comments from Joan or Dawn.
Okay, great. Thank you so
Next.
much.
Thank you. Next, I would like to call on Joe Engel. There we go, Joe. Yep, there you are.
Okay, I'm unmuted now. Hi, everybody. My name is Joe Engel, for the record, Joeengle. I am the CEO and founder of There Is No Hero in Heroin Las Vegas. We are a 501c3 nonprofit that helps adolescents experiencing substance use disorder. Just some comments. Initially, I read the 68-page document. 44 seminal documents were referenced by intelligent, very caring individuals that had already done some reporting from 2018 to this document. We have data. Let's move forward with it. I believe this document is somewhat comprehensive, and I am hopeful that it will help curb the stigma and use of opioid use disorder, along with stimulant use disorder and polysubstance use disorder. Recovery is not mentioned, in my opinion, nearly enough. As far as I can tell, I cannot see the word recovery mentioned in the recommendations. There's a lot of mentions of data optimizing, monitoring, surveillance, evidence-based prevention, et cetera, which are all fantastic. But let's talk about pushing forward. Let's talk about the acute problem that we now have, which is the opioid epidemic, which is killing people at an alarming rate. Let's talk about how we can get them treat the acute problem with treatment and subsequent long-term case management and housing. Attention is important to this epidemic. The correct attention will help turn the tide against helping to erase stigma. Every substance use disorder news story has negative connotations towards it, with lots of videos of needles and death. Can we please talk about and promote the therapeutic and nurturing effects of recovery? Treating opioid use disorder isn't a one-size-fits-all. Medically assisted treatment does have its place in the landscape, but should not be confused with being the holy grail. It is a complex issue that will take a multi-layered approach, including acute care, detox, supportive care in inpatient, long-term care, case management and housing, and finally, supportive neighborhoods, employment, and community centers and activities. Polysubstance use is a problem and should not be a hindrance to obtaining services. Youth will need special case management that will hopefully include a transportation hub, as dealing with youth has its own transportation issues. And background licensing and background checks for the providers that deal with adolescents. That's all I have to say on this, and I am hopeful that this will be a good thing for our state. Thank you very much for your time.
Thank you, Joe. The next person I have is Linda Haychef, which she noted that she submitted written comments, and those will be added into the minutes from this meeting. Linda, did you also want to speak at this time, or are you good with your written comments?
Hi, David. Thank you for the opportunity to speak. And I think I will wait and see if there's any feedback or questions from the written comments that we submitted. There's a lot to digest from us. We're definitely part of your solution, and we look forward to answering any questions once everyone's had time to review that, and appreciate your efforts of what you're focusing on in Nevada.
Thank you, Linda. And Dawn, to confirm, Joan as well, these written comments submitted by Linda's group, have we received those so far, or will those be included in these minutes?
Yes, we just got them this morning, and so we will review them, get them out to the committee, and then also have them as an exhibit within your minutes.
Thank you. The next person I have, I think that's it, but I do have Jose Melendrez introduced himself. Jose, did you want to comment for public comment, or are you just introducing yourself?
I just logged in and put in a good morning and hello to everybody. Thank you for all the work y'all are doing.
Thank you, Jose. Good to see you this morning. All right, we will move on to agenda item number 3. Public comment number 1 is now closed. We will discuss and take possible action to approve the minutes from March 24th meeting. Did the panel get a chance to take a look at the minutes, and do we have any comments or questions about the minutes? So the minutes looked good to me up until we get to public comment number 2. I didn't see a breakdown separating public comment number 2 from what I believe or appears to be the bios that were asked for from the committee of each one of the panelists. There seems to be I have some confusion on what is included, but nothing that would stop me from approving the minutes if someone were to make a motion to approve the minutes. We had some information about some people that are not on the committee, and it seems to me as though we're missing a few people that are on the committee that we didn't get their bios included in these minutes. But since we have received an email that does include all the bios, does anyone have any issues or questions about the minutes that were presented from last meeting? If you have your hand up and I can't see you, Joan, can you maybe help out? Okay, the only person I see is Joe's hand is still up, but I think we're good with him. Can we get a motion to approve the minutes, or if anyone has a problem with the minutes, now's the time to speak.
This is Jessica Barlow. Motion to approve the minutes.
Thank you, Jessica. Joan and Don, do we need a second, or can I go ahead and move to approve the minutes?
You don't need a second. This is Henna Rasul, Senior Deputy Attorney General.
This is Elyse Monroy. I'll second.
Thank you both. The minutes from our last meeting on March 24th have been approved.
You need to call for a vote.
Oh, yes, sorry. Thank you.
It's okay.
Okay, so I'll call for a vote now. If you can say aye individually, I would appreciate it, or nay if you don't want them to be approved. I'd like to take a vote now to approve the minutes from March 24th. All in favor, can I get an aye from you?
Aye.
Anyone that does not want to approve the minutes, can I get a nay?
Chair Sanchez, I wasn't here, so I need to abstain.
Thank you. I was going to ask for abstentions next. I heard no nays, but at this time I'll ask for abstentions. Anyone that didn't get a chance to check the minutes or was not present for the last meeting, now's your time.
Carla Wagner, I abstain. I was not here.
Thank you. At this time, it sounds like we have a majority vote for approval of the minutes from our last meeting. Does that sound accurate?
Yes, you're fine.
Thank you. The minutes have been approved from our last meeting, and we will move to agenda item number 4, which is a presentation and discussion from the Office of Minority Health and Equity on the health equity filter tools to address disparities across all racial and ethnic populations, geographic regions, and special populations. Tina Dortch, the floor is yours.
Good morning, everyone. And before I get started, can I see a show of thumbs up if you can hear me and see my PowerPoint slide? Thank you, Mr. Sanchez. Thank you very much. And good morning, everyone. As mentioned, my name is Tina Dortch, and I am the program manager for the Nevada Office of Minority Health and Equity. We also go by the name NOMI. In response to provisions of Senate Bill 390 from the last legislative session, the office recommended 6 members of the current ACRN structure. And when we last spoke with you, it was on November 18th, and it was an introductory presentation about the office and what we do. Today, I'm here to present for your consideration the use of an equity lens as you go about your work. And so why are we here? Why has NOMI been tasked with developing an equity lens? Well, it really comes down to the work that you do is so very, very important and significant. It's a huge undertaking as we address this issue. And it involves the input of many entities, such as this body, such as the Attorney General's statewide substance use response group, or SURGE. And it also involves involvement of the Department of Health and Human Services through our grants management unit, and even the director in certain instances. And so each of these entities share a commitment to equitable distribution of these future dollars to achieve a positive impact across vulnerable communities and those that are most marginalized. And so when we think about it, how are we going to do this? And what do we do beyond the Senate Bill 390's requirement to engage NOMI in the appointment of members to this body? Well, again, we're going to bring to you a method to help you bring to focus ways that you can infuse or embed equity into the critical functions and at pivotal milestones that you will be undertaking. And some of those milestones and those critical functions are, for example, priority setting and action planning. This is a huge function for the ACRN. For example, as you prioritize the findings of the needs assessment created by Mercer and to aid in the creation of an integrated state plan. It should be noted that Mercer did utilize an equity lens of their own in creating the needs assessment, and with input from the public, will be refining as they finalize that particular needs assessment. Another example about when and how to use this process is in the development by the Attorney General SURGE or the Department of Health and Human Services as they create recommendations for use of these dollars. And then lastly, the creation of the settlements pending NOFA process and any subsequent grantee selections or budgetary considerations Having an equity lens will definitely assist them as they create equitable decisions and solutions. And a key health equity principle in utilizing choice points is what we're here to talk about. We're going to be introducing choice points as a form of an equity prime. Engaging in equity prime, it's a process that evokes or it prompts the intentional consideration of potential impacts on marginalized communities. And when practiced consistently, evidence shows that you can become very, very accustomed to this type of thinking and thought process, and that it becomes part of the new standard when carrying out those functions like the three that I just mentioned. And then most importantly, and specific to this conversation, a choice point prime causes you to stop at each major decision-making point to ask a series of questions that were created to help you remove bias and promote equity from your final decisions. It should also be noted that choice point primes, well, they promote allyship, and that's so very important in the work that you're going to do. It in essence allows a person who sometimes comes from a perspective without lived experience to work in solidarity and partnership with those marginalized groups that we all seek to support and help. And then you also work to end those systems that enhance disparities and that challenge a group's basic rights or their equal access to resources. And in the case of your work, that might limit their ability to achieve or even maintain recovery. So in addition to this PowerPoint, you should have received as part of your board presentation packet, a choice point application guide. And so as part of your meeting materials, you have that to reference back to. In it, you're going to find examples about choice points that are currently in use. It's very interesting to note that many sectors utilize this type of thought process. The media, judicial systems, these are all examples where a biased outcome could have very detrimental effects. And so that's why the choice point concept was selected and for recommendation to this body. So as you embark on your work, I ask that you agree to make very deliberate choices and to avoid defaulting to the status quo or what we call autopilot decision-making, and instead to seek to reach conscious and equitable outcomes that take the needs of Nevada residents in all their diversity into consideration. So what does choice point thinking actually look like in practice? Well, one thing it does is it commits you to achieving a bias-free outcome. And so if you ever find yourself defaulting to the status quo, you would ask yourself, who stands to benefit from the choices that are being made if you are and you remain in that autopilot type thinking mode? And doing so will avoid unintended negative consequences or barriers to resources. Also, it looks like identifying decision-making points. This is a critical component to a successful choice point thought process. Making sure that you know every access point of impact, where historically underserved communities can then begin to experience improved service delivery and improved quality of life and wellness, because at these decision points, you're making very unbiased decisions. It also asks that you mindfully examine your choices when presented with them, that you brainstorm alternatives or options where needed, and that you seek to identify other options that could lead to more equitable results. And then once you know, next you do, or in essence, you begin to act more equitably. And you decide or select actions that reflect changes to biased behaviors or habits. And ideally, this step should include evaluating the results of your choices so that you can note the impact on equity and inclusion. And I want to just point out the image on your screen right now at the very top. I chose this because it's a very effective cue, a mental cue. In some cases, people find these cues useful to put into their agenda items and to list on each and every agenda, so that it just is a visual cue to remind you to engage in choice point thinking. And you do that until it becomes just standard protocol. And a regular use of these choice point primes, they remind us to pay attention again to bias and then to react strategically to alleviate them. So to be effective and resilient, an equity lens should be refined to the user. And that's why we have this slide and we discuss creating the Nevada equity lens. And we will be using, again, choice point primes. NOMI has identified the 7 categories of choice point primes that you see on your screen. And they're intended to assist you as members of the ACRN. These 7 categories represent a variety of equity-focused considerations. And selection of the choice point category is determined by the user, by the decision maker, and what their function is. So for example, will you be action planning? Will you be doing priority setting? Are you doing program design or policy development or resource allocation? Depending on what your function is, will then determine which of these choice point primes you will utilize. And as you see, number 8, there could be additional categories that you organically identify as a need as you go about your work. And again, as I mentioned, that guide that you have as part of your meeting packet, it does provide examples and additional templates, but it also defines some of the concepts that you see mentioned in these 7 categories. Things like the determinants of health and class standards. You will find definitions for those particular concepts. And then I want to point out that addressing choice point opportunities, this can be achieved while the ACRN fulfills your priorities. It's my understanding that additional input from the public is going to be sought as you further develop your priorities that govern your work. However, there are 3 fundamental governing priorities right now, and choice point thinking will support them. One of the 3 is that, does the topic before you increase the availability of preventative resources throughout the community? Also, it asks if the proposed use of the funds will save lives. And then that 3rd governing fundamental priority that you as a body have already adopted is that, is there a defined focus on addressing racial disparities? So as you adapt or adopt the choice point primes listed here, you'll do so keeping those 3 refined governing principles in mind. I'm going to use the next few slides to walk you through these 7 categories and explain how choice points could potentially be applied as this body goes about its work. And then at the conclusion, I hope to get some feedback from this group. First, I want to point out that choice points categories in the guide are presented using the template you see before you. And just explaining the template will be helpful, I think. So the first row would be listing one of the 7 categories that we've provided on the last slide. But then we also talk about the rationale for the priority or for the prime. And what this means is, how do you validate needing this particular category and what purpose does it serve? The 3rd row is where you would identify which of the decision-making functions are you engaged in. Again, are you action planning or priority setting or resource allocation? And then that 4th row is where those critical choice point questions come into play, where you are engaging with one another in an active discussion to ensure that the function is actually equitable and will result in a decision that is not biased. So let's go ahead and start talking about the primes and the questions. And the first prime, if you recall, was you need to determine where and which decisions can be influenced by your work. And the rationale for this particular choice point prime is that when you regularly identify all opportunities where critical decisions can be reached, the needs and impacts on marginalized populations can be further enhanced and ensured. I wanted to share an example for each of these particular choice point primes. And the example that I'm going to use throughout the 7 categories is going to be about your prioritizing the needs from the needs assessment into the state plan. And so in this example, as the ACRN begins prioritizing those findings, you should be asking yourself and discussing what disparities could be exacerbated among marginalized populations if a particular need is not prioritized for inclusion. That kind of a conversation will give you a robust response and make sure that decisions, again, are being done in an equitable way. The second choice point prime category is identifying those impacted at each choice point. And the reason why we have this particular category is the more thoroughly you connect with and recognize the diversity of the community you serve, the more equitably decisions can be developed. And again, the example that I'll use is that as you go about the work of prioritizing the needs assessment outcomes for placement in the state plan, this committee could discuss impacts on all subpopulations, including those that are identified as sexual and gender minority groups. Choice point prime category number 3 is about intersections with the social determinants of health. And the reason we include this particular category is that recognizing and integrating social factors that influence health-related behaviors and health status increase effectiveness of treatment plans and related programming. And an example of this would be that the committee could discuss the impact on employment or education or personal safety a marginalized community could experience if a particular need is not prioritized for inclusion in the state plan. The fourth choice point prime category, again, if you recall, is community integration. And the reason why this category is recommended is because meaningful engagement with historically underserved or marginalized populations promotes maximum benefit, and it also fosters resiliency. So an example of how this body would use that would be in discussing meaningful opportunities to keep the community engaged throughout all phases of the state plan, from its development to its implementation. And then the choice point prime category number 5. This has to do with the use of culturally and linguistically appropriate services or class standards. And the rationale for this particular category is that providing effective and equitable and understandable, also respectful quality of care and services that are responsive to a diverse community. Well, this does impact health beliefs and practices, and it also makes sure that health literacy is understood by all those who are seeking out services and resources. And the way that the ACRN could utilize this particular concept is that as you are looking at the action of the estate plan, you could discuss if the related delivery systems are presented at, for example, the 4th to 6th grade comprehension level. This is a recommendation of class standards. And then choice point prime category number 6 is about accountability. And the reason we suggest this category is that in addition to ensuring efficiency, establishing a transparent system of accountability cultivates confidence and trust that is often lacking in historically underserved populations. So an example of this in use by this body would be the committee establishing a process to provide resulting reports that you produce, the state plan, for example, to the impacted community, including its most marginalized members. And now the 7th and final choice point category is about data. I've already heard data come up today from some of the public comments that were made. And I just want to say that what I heard stands true to my comments, that traditionally status quo decision-making has been predicated on evidence-based initiatives that's supported by data. However, by itself, data does not produce a full story. And this is where things like social vulnerability indexing have become a recognized equity-focused component to the decision-making process. And for example, an SVI score, social vulnerability index score, it measures additional stressors a person or a community is experiencing. And it highlights their most challenging problems across all of those determinants of health. And it's important to note that these stressors can be human-caused or natural, and that there are many indexes that you have at your disposal in order to make sure that all those different instances are identified. There are several, but the most recognized is the CDC Social Vulnerability Index that was developed in 2011. And it's the default one that is most often referenced. However, I just want to add that when coupling this data and knowledge with asset building and mapping, this actually does improve the ability to get more effective results and resilient responses. And asset mapping really means identifying those entities, those nonprofits, those businesses, groups that you heard from in the public comments, for example, seeing how they can address the issues that were identified by the Social Vulnerability Index. And it's for this reason that Choice Point Prime category number 7 not only talks about data, but it talks about community-focused data. So that in addition to ensuring the effectiveness that data does afford you, it combines things like SVI indexing or community-based participatory research or equity-focused survey design and stratified data reporting. All these things come together to make sure that data supports a successful outcome. So in actioning this particular category, the ACRN could, for example, discuss the types and sources of community-focused data collection methods utilized. So that is an overview of the document, the guide that you have as your meeting materials. And again, this is a recommendation. We were asked to help this body come up with a system, a method to identify and go about your business in a way that removes bias from your decisions. And we suggest the Choice Point Prime process. And at this time, I'd like to know if there's any thoughts or comments about this method, and if you in fact find using Choice Point thinking a process that this body would find useful.
Thank you, Tina. Does anybody have any questions or comments for Tina after her presentation? Thank you, Joan, for your notification in the chat. Let's see if I can get a participants page up. I don't see any hands or anything from, oh, there we go. Got Elyse. Elyse, please.
Always Elyse. Thank you, Chair. This is Elyse Monroy for the record. I'm not sure if my question is for staff, state staff, or Tina. I have two questions. So I appreciated kind of the walkthrough of how the choice points, like the questions to think through, like the 7 types of questions. I guess I'm still not sure like what our expectation is as a committee to use this. So it sounds like Mercer used some form of an equity lens as their needs assessment. So then are we going to be using this method, this 7-question method as we develop each recommendation? Are we supposed to use the method looking at the gaps? So I think I would just appreciate some clarity on when we're supposed to be using this. And then I have a follow-up.
Thank you. Can you still hear me?
Yes.
I think the answer is yes to all of those examples that you asked about, Elyse. This is really a methodology that rebrands your brain so that you are thinking as you do make your recommendations, as you do take the Mercer report and needs assessment and translate that into your state plan. That in doing so, you ask yourself those series of questions before you come up with the final decision and the prioritization of those recommendations. And I would also say that this recommendation is just that. It's something that we prepared to guide that process, and that it can be customized, it can still be modified.
So then, am I supposed to take, so as a committee member, am I supposed to take that worksheet and fill that, kind of do homework and fill that in for myself and then come back and report to the group on what I thought? Or are we as a group working through this whole process together? And if that is the case, is someone going to facilitate for us? Because to date, the only way that we have been asked questions as a committee is the following. Are there questions, comma, any thoughts? Which is not a good way to draw information out of people. So if we are going to work through this pretty complex methodology for prioritizing with the health equity lens, is someone going to help us with that?
I can answer that from my perspective, and then I would ask the staff to augment my response. I think the most effective way would be a facilitated conversation, Elyse. And I think that facilitation would then net you a result that is then without bias. And I do think that there is a discussion that has been had about how to actually facilitate this conversation. I'm going to now again ask staff if that conversation could be facilitated. The Office of Minority Health and Equity would be willing to work with that process and facilitate that conversation. And yes, the template is intended to be kind of a worksheet, so to speak. And that will be part of that facilitation conversation.
Thank you, Tina, and thank you, Elyse, for your question. This is Chair Sanchez, and I would like to comment on what was last said. You know, Elyse, you put it perfectly. A lot of the time that we have to talk with each other after our presentation or as we're moving forward in these meetings is, any questions? What are your thoughts? Blank. And it kind of just goes silent. Sometimes we'll have people speak up if it means something to them, or if they have something that's, you know, that's irking them to say something. And so, Tina, as you were going through this, I'm looking at your slide that has the choice point and two different directions. And the best that I can come up with is, I'm responsible in the moment to say, are we considering equity in this decision? And that's rough. Like, I'm with Elyse. That's like, I mean, and really what I wanted to say after hearing your presentation is, someone else here on the committee, please commit with me to speak up when we may have overlooked the view or perspective of, is this equitable across the board? And then what we're supposed to just be able to check each other on it. So I don't know what a facilitation of a conversation or an implementation of this type of lens looks like as we move forward and make decisions, especially if we continue meeting and talking and making decisions like we have been, where a presentation is given, a topic is brought up, and afterwards we simply say, are there any questions? Does anyone have a comment? And we move forward. It seems like a lot of autopiloting through most of this. At the same time, I understand the, I don't know how to put it, the facilitators' view of this group and us moving forward, is we could be stuck for hours talking and, you know, giving our opinions about the material presented, and just be stuck in that phase and not really moving from meeting to meeting and getting to a place where we get something done, which I think we're going to have to find a balance between the two. The facilitators want us to move forward. The group wants to be informed. The group wants information. And the people bringing us information are doing the best they can, but we really don't have, or we haven't had too much of an opportunity to break things down, which is one thing, but I think in the back of my mind, I have a little bit of a fear that we will rush forward too fast and be left to a point where we all just raise our hands and fight for the little bit of say we can to have what our interests are pushed forward towards the final decision or the final recommendation to the state. I have a comment in the chat from Dawn that says she would recommend a subcommittee. And I guess that's the way to go with it, is that maybe we do need to create a subcommittee. And again, just if someone could help speak to this, the subcommittee would then be responsible and accountable to make call outs as we make decisions and ask for information, so that we're ensuring that we're taking an approach that provides for an equitable lens. Does that sound on point to everyone? Do we have any comments or questions about what was said?
Chair, this is Carla Wagner. I have a thought.
Please.
It might be because I was added to this committee late, but I just want to maybe echo what Elyse was saying, that I'm really struggling with understanding where and when and how the work gets done that I am supposed to be here to do. And so maybe if I'm not alone in that, the committee might benefit from kind of re-emphasizing our charge and our process a little bit so that we know what we're going to do. I would hesitate to delegate the job of ensuring equity to a subcommittee or a certain set of people. I mean, I think I would kind of be more on board with the spirit that this is part of how we're all supposed to make our decisions, and so it should infuse our whole process. But for me, what I'm struggling with right now is I don't really understand what my job is or what the process is. And I might be alone in that, in which case I need an offline refresher, but if not, that's really what I need right now. I'm certainly happy to embrace and work through a process that is deliberately designed to ensure equity in our decision making, but I need to understand a little bit more what my job is first.
Thank you, Dr. Wagner. And I'm with you. It's a little muddied up. My understanding, and please, if anybody else would like to join in, please just unmute yourself and speak up. I'm with you. My understanding is muddied in that we're part of this committee. We will ask for information. We will be presented information. And finally, sometime down the road, we will make a decision of recommendations to the state based off of the information that we've been given and with a little bit of talking about it. I guess what it seems like to me is that we might need to add another meeting. And again, the biggest problem that I'm seeing is almost a sense of rushedness. Like, we need to be quick about this. We need to move forward. We can't be locked up in talking about it. But it seems like we may need a working group of the full committee to meet and to make sure that the same sense that Dr. Wagner is feeling and that I'm also sort of feeling, we all come to a place where we're comfortable and clear on how the process is going to work and really what our time limits and restraints are. Are we allowed to interrupt, and take the time that we need to be clear on information provided and present this gigantic list of questions that we have, or this gigantic list of information that we would like to see in a more open and I want to say comfortable setting? Because right now it seems like everybody is just here to listen and kind of on the fence about whether or not they should interject with saying something. Does anybody want to speak to that?
Jessica Barlow here. I could totally agree with what Dr. Wagner and yourself just said. I do feel like maybe we do need some kind of sit down as the committee again to just kind of reiterate what the purpose is, what the timeline should look like. And in general, I too feel like I understand why we're here, but I don't know what it should look like as we go through that job. And it would be nice to understand what us, making these decisions and getting this information, what it should look like timeline wise. I mean, just a little more clear cut understanding of the purpose, I guess, for sure.
Cornelius Sheehan, I would like to, I'd like to join those comments as well that Dr. Wagner offered and started, and the rest of you echoed or joined. And, there is this balance with, I feel a sense of urgency. I think one of the public commenters, maybe Mr. Engel, brought that up. I know all the rest of us do too, especially if we're close to things happening on the ground. And so my experience has been that just getting together with you monthly, doing work in between, I haven't had the opportunity to collaborate as much as I'd like. And I know we all bring, different expertise areas, and that's part of why we were selected to participate. So that seems like a missing element. And there's just a lot of expertise, a lot of varied experience that can inform this process, and finding a mechanism to make that happen. That's still within a reasonable time commitment from people is something I'd like to see happen, or like to talk about and explore, and would be willing to do whatever I could to facilitate that.
Absolutely. Thank you, Cornelius. I'm not sure if anybody else has their hand up, but I would like to say that I think one thing that in the back of my mind that creates a barrier is part of this group and the lack of I just lost the word of working it out together and talking to each other might be in part due to the open meeting aspect of this committee. Ms. Rasul, can you give me a brief explanation on any conversations that we have with each other as a committee? My understanding is that that must be set up as an open meeting for the public to be involved with. And if that's the case, does that have to stop us from collaborating together?
You can only collaborate during an open meeting as a group. That's just the way it is as a committee. Even if you create a subcommittee, that subcommittee would be subject to the open meeting law as well. Or a working group, or whatever you want to title it as. Even if it's a smaller group of people, that subcommittee would only be there to discuss whatever topics are designated to them, and then whatever decisions they make would only be recommendations, and then they'd be brought back to this committee because this is the main committee. But you cannot meet outside open meeting law.
Thank you.
Or an open meeting, public meeting.
Agreed. Thank you. Elyse, please.
Thank you, Chair. So I know that open meeting law can kind of feel like a bear and something kind of laborious to have to work around. But transparency to the public, I think, is something that's really important. And I actually don't know if what I'm feeling hindered by is the confines of and constraints of open meeting law. I feel like what I'm feeling constrained by is unclear expectations from the state agencies we're working on behalf of. So I think we've had 4 or 5 meetings now, and it kind of feels like whenever there's questions about the process or what we're supposed to do, we're just pointed back to Senate Bill 390 with very little explanation for a timeline or a process or products or deliverables. It's like, well, this is in the bill, this is in the bill, this is in the bill. So I think if we as a committee could better understand what our deliverable as a group is, it would be helpful. But what that would also do would help the committee, or excuse me, the public have a better understanding of this process. Because what I hear from community partners is that this process is not transparent, and that many people in the public space feel like decisions have already been made because it feels not transparent, which I don't believe is the case. But I think if we can get to a place where expectations and deliverables from this committee are a little more laid out and more clearly defined, I think we will all be able to get the machine of this process kind of moving and rolling. But I don't think it's because of open meeting law. I think it's because we don't have clear expectations for the process. I mean, there's so much thought that has clearly been put into the health equity model, but when I asked for clarity on what our expectation as a committee is, it was even vague. When are we supposed to use the tool? And there's 3 options in the process. Yes to all. What does that mean? What does that look like? Is it going to be facilitated? Yes or no? So I think just some more definitive expectations and clarity would help the process a lot.
After what we've talked about so far, I kind of feel like I'm not doing a very good job as a chair, as leading this group and kind of guiding it forward. But
no, so this is Elyse. I don't think it's that at all. I think that it's an unprecedented situation for everybody involved. It's
Okay.
it's an unprecedented amount of money. It's an unprecedented public process we're trying to work through. It's an unprecedented way, I think, that the state has like prioritized input from people and groups that haven't historically been part of the process. Like, this is hard because it's like never been done before. That's really freaking cool. Like, that we are all here and we get to be part of that process, but it's hard because we're all trying to figure out what the process looks like. So you're doing a wonderful job, an excellent job. This is just a hard thing because it's really new.
Thank you. Thank you so much for that. And Dr. Wagner, I'm going to call on you in just 1 second. I just wanted to say, well, that's awesome that you pointed it out that way, because then we have a responsibility to not just sit by and hold those feelings of unsureness. We have a responsibility to say something and then work together to come to a solution. So that sounds like what we're on right now. I know we're supposed to be moving on to another agenda item, but Dr. Wagner, please, let's continue this conversation.
Thank you, Chair Sanchez, Carla Wagner. I just wonder if we could, as a committee, or you as chair on behalf of us, could ask for a little more specific guidance about our charge and the deliverables, and maybe I don't know if there's an opportunity to ask for just a little bit more assistance. As Elyse pointed out, none of us have done this before. Everybody's trying to work it out. I think we all have the best interests of the state and the people who live here at heart, but maybe we just need a little help. Is there a way to ask for that?
Yeah, I think there is. I think what we need to do, and somebody correct me if I'm wrong, is set another meeting. And during this meeting, we'll have the state entities that are put us to this task, present to us what it is we're supposed to do, not just a simple layout of a verbatim of 390, but also a little bit of personal connection to that reading of what we've been tasked with through 390, but also a place that we can then say what we need to say, our questions, our clarifications, without embarrassment, without feeling bad that I don't know, without being shy because it sounds like a dumb question. And then yes, exactly, right. Dr. Kanyar just said it perfectly. Like, we are using the lens in and of itself by not just rolling with it any further. So we have the rest of the agenda, and we have another meeting scheduled, but I'd almost like to ask or see what it would look like to change the nature of the next proposed meeting to a meeting of presentation by state entities of our task, and also have a place to where we can ask questions about how to get there. Can someone give me some comment or clarity on?
Yes, Mr. Chair, I think that's an excellent idea for next meeting agenda.
Let's slow it down a bit. Get on the same page.
Mm-hmm.
Dawn, what do you think about that?
That's fine. If you guys want, this is Dawn for the record. If you guys want to do an additional meeting, please let us know. If you want to have one in 2 weeks instead of the in 4 weeks, like it's planned, in order to do this and then continue on your process, or if you guys just want to remain with the meeting on the third week in May, then we can do that as well.
So I know that this is people are taking their time out to do this, and we really, really appreciate it. And I'm glad to be here and give whatever time I can, but I don't want to put too much pressure on the committee to have a meeting in 2 weeks and then 2 weeks after that. But I would advocate for that. That would be my first choice. As many as I could participate in, and as much as time as I could give, I would like to do that. So I don't know if this is the place or the time, or if this is a possibility, but at this time, I would like to ask the group if they are interested in meeting in 2 weeks to kind of go over what we just talked about, or if we should just swap our next meeting, which is scheduled for May 18th, to get done what we just talked about. Do we have anybody to comment about that?
So what's on the agenda for the next meeting? That might help decide. I'm not sure, staff, if you know, or if anyone knows if we're just going to be finalizing the needs assessment or like, I don't know what was scheduled to be during that meeting.
This is Dawn. I know that we were going to be going through the actual recommendations from the public comment as well as the ACRN for the finalized needs assessment.
So go ahead, Cornelius.
Mr. Chair, Cornelius Sheehan. I would love to meet in 2 weeks. I'm a office-based clinician and do mostly outpatient work, and it's really difficult for me to shift things, and I'd actually sort of jeopardize the care of the continuity of care for some folks. Would run counter to this, to our agenda. But I would love to, in the future, if it was scheduled out, I'd be more than happy to clear that time. And I think it's a wonderful idea. So count me in with a little bit of time to move my schedule.
Thank you, Cornelius. And I think we'll find that across the board. You know, we're professionals busy, embedded in our communities. So for now, I don't know if I need a second or if I need somebody else to agree to this, or Dawn, you can speak to this, but
this is Tina, your Senior Deputy Attorney General.
Okay.
You might want to just stick back to the agenda because you could probably address this more. It can't be an action item because you can't take any action. It's not agendized for that. But what you are on topic for is agenda item 7. That's kind of where you're at right now. But I would maybe postpone and wrap it up at that time. But again, it's not an action item, so you would just further discuss.
Okay, thank you so much. Any closing comments to the conversation we just had on our next meeting? If there are none, I'm going to move forward to agenda item number 5.
Cornelius Sheehan again, seeking clarity, possibly from Mr. Rasul, regarding open meeting adherence. Can we submit documents? So if I come across things that I think would be of interest to the committee regarding an agenda item, can I submit those between meetings, or do I have to do it when we're together? I'm new to this process.
Oh, that's fine. You can submit them to staff, so Dawn or Joan.
Okay, thank you.
Great, thank you again. So at this point, we'll move to agenda item number 5, presentation and discussion from Mercer on the final draft needs assessment in compliance with Senate Bill 390 legislation. Go ahead and take it away, Dr. Cantrell.
Hi, this is Courtney Cantrell from Mercer. First, I forgot the trick to getting the right thing on the screen. Because I think you're seeing my kind of speaker note version right now. Sorry, give me just a second. Nope, that didn't do it. Okay, I'm going to reshare with my other screen. Okay. There we go. So is everybody seeing the actual full screen of the presentation?
Yes.
Yes, okay, thank you. It's hard to zip between Zoom and Teams sometimes. So we are going to present to you today. You've gotten a copy of just the first draft of the needs assessment. And again, that needs assessment was based on about 30 seminal documents. And this is part of that process where we're going to get feedback from the ACRN committee on other things that might be missing from it, or any other feedback that you guys have. And then we'll be editing the report after that and doing some other work on it. The document that you were given does not include recommendations. There are some kind of mentions of recommendations in the report just because it's kind of hard to give gaps sometimes without talking a little bit about what could help. The whole recommendations section, we have some ideas lined out from our expertise, but what we're really waiting for is the public comment section and the feedback from you guys in the ACRN on what kind of recommendations you want to see based on the gaps or based on what you have in your community. So that's what we'll do when I'm finished with the presentation. We'll open it up for feedback on the report and for those recommendations that you guys want to make sure get in there. I will say, let's see, for the next one. So again, I'm going to do an overview again, just to remind you guys of what the flow of the assessment of this draft of the assessment report looks like. I've gone in and we've gone in and pulled out all of the gaps that we found as we were doing the needs assessment, and put those in slides so that we can discuss kind of different sections, different areas there are gaps that were identified by the data. And then finally is feedback from ACRN, both on the report and especially on recommendations for what you want to see done to address some of these gaps. So again, 7 sections in the report. It goes from background to methodology, which is all the documents that we used in it. The impact that opioids had, which is mainly the statistics on kind of where Nevada stands right now when it comes to opioids. A section on polysubstance use, co-occurring conditions, and suicide impact, and how they play into the state's services and the opioid issue. Individual and system level risk factors for both opioid hospitalizations and opioid use for individuals and for your whole system. Best practices in section 6 was actually based on a Johns Hopkins report that included a juxtaposition of Johns Hopkins report against what's currently going on in Nevada. So that's what we were working off of. I don't believe we grabbed the newer one. We grabbed the one that actually had Nevada information in it. And then finally, again, the recommendations aren't there because we need those from you guys. So the first thing we're going to go through is data gaps. Now, there are a lot of gaps in data. You can say this about any state in our country. I'm pretty sure. I don't know for sure everyone, but data is always a little bit fragmented because people collect data based on what they need for their programs. So when you're looking across an entire system and trying to figure out what's needed and what's missing, that's when you start to notice the glaring gaps, because organizations may use what's good for them and what works for them, but then there's holes missing where there aren't organizations working in those areas. So when it comes to overall, there is a bit of a lack of a standardized approach to data collection across the state. Again, it's not something specific to Nevada. Every state deals with this. Makes it kind of hard to compare data sets and draw firm conclusions. So when an organization says, here is the data on people with substance use, there are 15 different ways you can figure out what that data might be. How many people have an alcohol use disorder or an opioid use disorder? So one of the gaps is that there's not a standardized way of looking at all of these data elements that can paint a picture of the real issues in the system. So the limited or lacking data is one part of the data gaps. We particularly identified that it's hard to find out what drugs tend to be co-prescribed with opioids, specifically in the prescription drug monitoring program. Demographic information is kind of missing from that PDMP. We don't have a lot of data on pregnant women and opioid use. There's some, especially in Medicaid, but there's probably a lot more going on out there that we're not quite aware of. The welfare system has a lot of data, but we can always use more when it comes to children and parents and the kind of issues that are going on with opioids in those cases. Health outcomes for those in substance use services. A lot of individual providers keep health outcomes. A lot of state-funded services have health outcomes, and Medicaid services have health outcomes, but they may not be the same. And there may be some missing for specific services. So we have that as a gap as well. There is a gap in the availability of evidence-based practices. So it's hard to know where individual providers as well as facilities are using evidence-based practices and what they're using and how many people are receiving those evidence-based practices. That's not an easy data gap to fill, but it is a data gap, especially when it comes to treating people who have multiple substance use and other behavioral health and physical health comorbidities to the issues that they're seeking treatment for, because those treatments often need to be tweaked for that. The specific substances that tend to be involved in suicide is another area where we don't have quite enough information. And that goes into, as Elyse knows well, the reporting on the death reporting and death certificates. And those can be very complicated pretty much in all states because they come from different places and all have different information. Physical and mental health diagnoses for those using opioids. We have some information, most of it's national. So it would be good to have a little bit more across all payers information on the kind of mental and physical health diagnoses that people deal with who are using opioids. And then across all of the data, it is always important to have some of that race and ethnicity data so that we can know who's getting served and who isn't. Housing status, so are people who don't have stable housing, are they getting as much treatment as the people who do? Probably not, but we don't have that really great data on that. On the veteran and military status for people that are in treatment. or who have overdosed. Again, pregnant women, people of LGBTQ status, how they identify, that's certainly not something that's often collected right now, and it could be collected in the future. And then finally, the people who have a different immigration status or aren't otherwise connected to a treatment and payer system, that's a gap. There are people that just aren't being counted. Again, those solutions are much more difficult because the data is limited, and because the reason they're not being counted is often because the information's not there. But we have to keep it on the radar and find ways to include those people so that we can serve them better. So the next one is prevention. And I think I forgot to mention that I'm going to go through data and then prevention, treatment, discharge and recovery, harm reduction, and social determinants as the different areas of gaps that we identified. So when it comes to the prevention gaps, first we're classifying that public education and stigma is a big part of prevention. Community-based prevention programs, we've found a need for them across all counties. Again, we had seminal documents, and then we collected some more beyond that. Sometimes the documents we have might not have all of the information, so that's where it is good to get information from ACRN and the public on other things that you guys know about that are out there that weren't necessarily in our reading. The Zero Suicide Initiative is being implemented in Nevada. Nevada could use more of it to help with some of that public education stigma and accessing treatment. I will also mention school-based prevention programs, and prescription drug disposal, especially in the southern and rural regions, was listed as something that needed to be beefed up in those areas. When it comes to stigma, education for school systems, parents, and for law enforcement can be very helpful. There's also a lack of education on the addictive potential of opioids. So the UNLV study, the qualitative study that was reported last time you guys met, was really rich in information, because a lot of times there's not data on what we don't know. So if it's a gap, we not even know it's a gap because we haven't heard from people. So it's wonderful that we have not only that UNLV study, but another study that was done a few years ago of about 35 people who use or have used opioids. They gave us a lot of information too from those reports. One of them was that especially people in rural areas didn't feel like they got information on the addictive potential of opioids or alternative therapies like acupuncture and chiropractic and cognitive behavior therapy and things for pain. They didn't feel like there was much education on treatment options, especially for people who don't have housing, because we all know if you don't have housing, treatment's not going to be the first thing you're thinking about. You need to figure out where you're going to sleep each night. And then education for family members. So when someone's in treatment, the family members were often experiencing anxiety and really not sure of what to expect or what treatment was, especially when it came to medication-assisted treatment. There's also some lack of education from the reports we're reading among high school students around substance use, around the awareness of the opioid epidemic, how to use naloxone, and their attitudes about discussing these topics with healthcare providers were low, but it actually increased in an intervention that was done in the study. And finally, stigma was reported still pretty strongly by people with lived experience through difficulty obtaining and keeping housing and employment. They had a lot of anxiety about seeking help, especially veterans and tribal members, because veterans, as she mentioned last month, are worried about losing their veteran status. And tribal members, of course, those are close communities, and there can be a lot of stigmatization around it. So whereas some of these were data-based in a qualitative way, they were super valuable because they gave us that information. So it may look like we may see that there are a number of prevention programs for stigma maybe around the state, but people are still reporting that there's a lot of stigma, especially with healthcare providers. And when we notice that, it means there's still a gap there, even if we're not entirely sure exactly where that gap is. So there's also prevention gaps when it comes to provider and prescriber education. Education of patients by prescribers on pain management. I kind of mentioned that in the last one, and on those risks of opioids, but more providers probably need education on how to talk to their patients about opioids. Referring to other pain management programs is also very important. And again, that stigma that some healthcare providers may experience that, that some people getting healthcare from providers are still reporting that they do experience. There's also a need for maybe more pre-treatment screening and care plans that include those alternative payment or alternative pain management. So including in that, having a comprehensive care plan that does include psychosocial factors and like I said, acupuncture and chiropractic or whatever else may help the pain. And then education and monitoring around opioid prescribing and dispensing. You guys have been doing a great deal of that. There's still some indication that prescribing and dispensing is a little high. Nevada rates in overall in the past couple of years have been higher than the national average. And Carson City in particular is double that. I think it's 95.1 per 100 people. So almost everybody in Carson City could have their own opioid prescription. They don't, but that means a lot of people are getting overprescribed. And finally, participation in Project ECHO, which you may have heard of. That one is a great way to educate providers and to bolster their competencies in certain areas, especially related to opioids, prescribing, to all of these things we're talking about. Nevada already has Project ECHO. It could always be enhanced and improved and expanded. And that's a lot of the recommendations are probably going to be around expanding things that are working well within your state, which is why it's good to know what's working well within your state. So when it comes to treatment gaps, those are divided into some general treatment gaps, and then I'll go through the outpatient treatment, withdrawal management and residential, and then the crisis system. So when it comes to general treatment gaps, I probably shouldn't read all these to you right now, but it's kind of hard to skip anything. This treatment availability across the bigger needs assessments that we read was that, along with housing, were the two things that really stood out that communities voted that they needed the most, was making sure that there was affordable housing and housing for people, and making sure that treatment was available across the state. An insufficient healthcare workforce was one of the biggest things that was cited as a reason the treatment gaps seem to exist. Rural areas seem to be hit the hardest when it comes to those disparities of not having, in particular, opioid treatment available. And while we couldn't find Nevada level data, the national data does suggest that there are disparities for ethnic and minority youth. And I will also say that there is an interesting thing that we noticed when looking at minorities. And it's, again, we don't have the data that we need to really compare apples to oranges. But when it comes to like the Medicaid population, one report said that it's about 36% white. When you look at within Medicaid, the percentage of people that are receiving treatment, it's about 84% white. Now, these may be different years. Again, we don't have data to pull it all together, but that's a pretty big difference when 36% of the people in Medicaid are white, but 84% of them might be receiving treatment for OUD, for opioid use disorders. Whereas the population of Black people is 21% for Medicaid, but only 9% of African Americans are receiving any treatment within Medicaid. So you can kind of infer some disparities. Again, that data is not quite in the report because it's comparing a little bit different things, but it's one way to look and say, yeah, there's an indication that there is definitely some health disparity, which I don't think is surprising. Let's see, so that's the overdose data that I'm talking about that kind of looks a little bit strange when you look at different racial breakdowns. Peer support is something that's mentioned often that's needed more in treatment, and in the qualitative studies, people also mentioned that was very, very valuable to them. A little bit harder to do in rural areas, but very valuable to them. A lack of community-based accessible resources after release from the justice system in particular, whether it be because of the payer issues or just dealing with all that people have to deal with when they're released from the justice system. That's a big need for them. Treatment access for pregnant women. A lot of times pregnant women have a tendency to not access treatment for a lot of different reasons. There's stigma, there's fear that they'll lose their child once they're born, if they admit to using these medication or these opioids. And there's also a problem sometimes with providers not wanting to take that risk of prescribing for pregnant women. So there's also drug courts. You have drug courts, other treatment and housing services, but they're not necessarily available statewide. So that's mentioned as something that could be expanded. National studies did identify a gap for youth that are in the juvenile justice system. So we kind of infer that Nevada is probably experiencing a similar gap. Nevada SAPTA does have a great certification system for people in treating co-occurring disorders. So that's mental health and substance use disorders together, especially for youth. But there aren't that many providers that are currently certified for treating those co-occurring disorders, and especially not for treating them at the highest level of fully integrating the treatment together. And finally, says both mental health treatment is needed. I believe that Nevada is 51st in the nation for youth when it comes to the access to mental health treatment. And as much as we know about how mental health treatment mental health disorders put you at higher risk for substance use, and opioid use puts you at higher risk for mental health disorders, mental health treatment becomes a very big part what is needed for the opioid epidemic as well. And then finally, a screening, identification, and referral to treatment. A lot of what we saw in the data was that, you know, there are OTPs, opioid treatment programs out there that have capacity, but they're not being used at their capacity. Or we have office-based opioid treatment, that's docs giving buprenorphine, but they're not giving that medication up to the level, the number of people that they could. And a lot of the reason that they've listed may be that they're not getting the referrals, which leads us to imply that people really aren't being screened or identified to the degree that they need to in order to get them treatment. So capacity seems to be there for some treatments, but that may be an illusion just because people aren't getting screened and referred. So specific to outpatient treatment gaps, psychiatrists and psychologists are needed. Like I said, there's some evidence that more OTPs and office-based opioid treatments, that's what that OBOT is, are needed in certain areas. But again, I think that if people were screened up to capacity, then we might need more. Outpatient detox, licensed drug and alcohol counselors, especially in rural areas, are needed. MAT in rural areas and on reservations, that medication-assisted treatment is definitely a necessity there. And sometimes the need to have both the prescription and the counseling at the same time can make it harder to implement MAT in places where you don't have a great big workforce. Mental health treatment during and after MAT. So UNLV's qualitative study also indicated that mental health treatment during and after MAT was a big concern of the people that have experience in the opioid area. Justice facilities seem to be lacking in their medication-assisted treatment, and there's a critical need for outpatient treatment for youth who have co-occurring disorders. As we know, that's a big deal. I will say there was recently a new study that the heroin the fentanyl-based fatalities have gone way up. And the national study said, well, it's probably not because more kids are using heroin, it's because they're using more of it, and it's not or opioids, and it's not what they think it is. But one of the other things may also be that with the pandemic, it's also people's mental health struggles are more, and so there's more leaning on these substances for coping. So again, outpatient-wise, more mental health treatment for those with and without SUD to prevent it, and then a lack of formal collaborative care for individuals at risk for suicide. So when you're dealing with people who are at risk for suicide, if opioids is a part of it, that is a big part you need to collaborate and treat as well. So withdrawal management, inpatient and residential services, have that separate because that is a kind of a different area. Community support during detox is a bit low. The qualitative studies have said people commented that they're required to stay in their current community while they're supposed to detox before they can get into treatment, which is incredibly difficult for people who are ready to change. They stay there too long and they're not ready to change anymore. They've kind of given up. So one big gap was that, kind of to bridge the I'm ready to change now to getting them into treatment and supported as soon as possible. Facility services are, as I'm sure you know, mostly in urban areas, and they're lacking in rural. And if they are in a rural area, transportation's even worse. So it's that transportation plus having services that are a little more local to be able to access. Short-term and long-term rehabilitation is listed as a gap in some other needs assessments that were done around the state. And then withdrawal management and residential services. For the Medicaid population, the way it is right now is people who are 18 to 64, or I guess 19 to 64, can't access those services under Medicaid because Medicaid can't pay for them because of the way the federal Medicaid classifies those facilities. But the state has proposed an 1115 substance use demonstration waiver that, if passed, would then open those facilities up to be paid for by Medicaid for the ages of 18 to 64, which would be great for your population. So if that comes through, that should increase capacity. Maybe with more business, maybe they'd be able to expand a little bit more too. But that is one of the gaps. And finally, under treatment, the crisis system. Nevada does not currently have a comprehensive and consistent 24/7, 365 statewide system. Mobile crisis is needed, especially outside of Central Las Vegas. Central Las Vegas has your CCBHCs, you have EMS, you have MCRT, you've got a lot of crisis stuff there that handles both mental health and substance use crises. But the rest of the state and some of the more outlying areas may have a little bit of this or a little bit of that, but not a consistent system that is of the quality that it needs to be right now, or that performs the way it does. Crisis stabilization units, Medicaid's currently working on those, but they are definitely a need, as well as the need for follow-up to crisis, follow-up after crisis to ensure stability and address barriers to care. That's a big need, especially for people with substance use, because we can refer them, but we need to check up with them and make sure that they're not experiencing barriers to getting into that treatment. Oops. Okay, next to last one, discharge and recovery support gaps. So funding and insurance for long-term care for recovery and residential programs was listed as a gap. A lot of people also in the qualitative studies said that they just didn't understand how to access those kind of recovery supports, or even how to fund treatment. So that's a gap that we've identified as well. Insurance often limits the duration of treatment, especially for these, the after discharge and some of the recovery supports that come on after someone's discharged from the facility. The qualitative studies, and that's what a lot of this was from qualitative studies, but people talked about having an inadequate discharge planning, coordination, and communication between levels of care. They felt like when they left one level of care, they were just starting over with a new provider and starting over, just really, really not understanding how to bridge that gap between where they were coming from to where they were going. And they had to start all over again. Maybe they had to tell their whole story yet again, which can be very sometimes traumatic and difficult. So when it comes to discharge programs for individuals that are released from the justice system, as we mentioned earlier, it tends to be a gap from one system to the next. And a lot of justice systems have some treatment, or their de facto treatment, and the person stops when they're in there just because they can't access it. So they need some discharge planning to help them to get into those aftercare and recovery supports. The recovery community talked about religious or spiritual advisors, faith-based organizations, and 12-step programs in rural areas being needed. Something that they saw as very helpful, but not very, very prevalent. And education and support on things like parenting, going back to school, getting health insurance, including Medicaid, on the maintenance of recovery and the process of recovery, how it's a long-term thing. It's not something that they're done with when they leave their treatment program, and the need for recovery centers across the state. So finally, harm reduction and social determinants of health gaps. When it comes to harm reduction gaps, things like needle exchanges were prominent. So there are some places that do have great needle exchange programs, but others don't. In rural areas in particular, it sounded as though that was a real challenge, in part because rural areas are small, everybody knows everybody. So if you're going to go do a needle exchange or a safe place to use or something like that, then the police know where it is and they're driving by too, and your neighbors know where it is. And when they see you there, then they know that you've got this issue that you're dealing with. So people in rural areas really struggle with how to use harm reduction. In general, education about harm reduction resources and methods, including how to use naloxone, was something that was reported in some of the papers as a need. And then of critical importance as well is the social determinants of health. In tribal lands, income is lower and unemployment and poverty are higher. And so there tends to be a higher risk for some of these things in those areas. Housing vouchers and affordable housing, especially in some counties in particular. When you have these kinds of needs of income, you've got unemployment, you've got housing and transportation issues, you're going to be, of course, at higher risk for using opioids, and it's going to be a lot harder to access treatment. So as I mentioned, transportation, not only to treatment, but also to access employment, vocational stuff, volunteer opportunities, that transportation is really a big barrier for people. Employment for those receiving treatment and in recovery, the qualitative studies had people talking about how they would like to have a job. They would like to keep their job, but often that can be difficult while you're in treatment and post-treatment during recovery. Volunteer opportunities they wanted more of. It was mentioned that internet access is something that's needed, as well as food access and financial resources and stability for those who are in recovery, because often having a job is difficult in treatment because one needs to take priority scheduling wise, and that can be difficult for people. So overall, these are the gaps that we found. Now, what you don't hear a lot about in here is youth in particular, or is different racial and ethnic gaps. That's because there wasn't enough data for us to say specific to this race or ethnicity in many cases. But what you can take from this is with Dr. Dortch's tool, when it comes to the recommendations to fill each of these gaps, that's when you can start to say, well, we need to make sure that whatever recommendation we have for, let's say, needle exchanges, does promote equity and everyone's access to that. So it's kind of setting a framework around all the solutions, because we didn't and often find data that shows there was a disparity. There probably is, but when it comes to recommendations, that's our opportunity to make sure that we don't recommend things, or that you guys don't as a committee recommend things that aren't going to be equitable across races and genders and such. So that is the end of my presentation. So I think we're opening it up now, and correct me if I'm wrong. First, for feedback from ACRN on the needs assessment, right, Dawn? Okay.
Dr. Wagner?
Hi, thank you, Carla Wagner. I have a couple of comments and a couple of questions. So is this do I get to just say
Yep.
what I want to say?
I think so.
Okay, so two comments first. One thing as I'm listening and as I'm reading through the needs assessment, I would like to encourage us to think about how we use the term harm reduction. In the field, harm reduction is not simply distilled down to a set of interventions, something like a needle exchange program or an naloxone distribution program. Harm reduction is also a way of thinking and an approach to engaging with people who use drugs and who are at risk for overdose that explicitly values their autonomy and their dignity and their agency. It's a philosophy similar to what we heard about earlier in terms of embracing an equity lens, in terms of our approach to everything that we do. And I would like to encourage us to think more broadly about how we use the term harm reduction to infuse the work that we do all along the continuum from primary prevention to treatment and recovery. I use a harm reduction perspective in the work that I do, and it is an attempt to reduce the harms experienced by our communities and the people in them. So rather than just siloing, these are the two harm reduction strategies that we do, I would like to think a little bit more broadly about what it means to embrace a harm reduction perspective. A couple of things that I didn't hear in the presentation and that I didn't see quite specifically in the report that I would like to just bring back up for discussion at some point is in terms of information gaps. I think I've mentioned before this idea of fatality review boards. We have models for fatality review boards for other kinds of circumstances related to death. And as you pointed out, there are difficulties in understanding death data, especially when we try to aggregate them, but we could be looking one-on-one at how deaths occur to better understand the circumstances and identify missed opportunities for prevention upstream. So I would like to just put that back on the radar. I understand it requires some other kinds of legislative actions, I think, but I think it's something we should consider. And then specific to the report.
And can I just say, so when it comes to the information gaps, like what you just said about the fatality review boards, I consider that a recommendation.
Okay.
You know what I mean? So that's what we can actually tag as one of the recommendations recommended by ACRN, if that's
great. Okay, so I had a few questions kind of about some specifics, and I'm hoping they're in the report, but if they're not, I would like us to find them. You said something about treatment gaps on racial disparities, and it sounded like what I was hearing was the proportion of people who are insured versus the proportion of people who are receiving substance use disorder treatment services based on race, but I wasn't quite sure. And so I would actually like to see that kind of those data tables if you have them. And then another thing that almost came up in the talking, but I would like to just point out as something that I think we need to look into a little bit more closely is in terms of implementing prevention strategies, there seems to be some conflict between the provisions of some of our efforts and law enforcement strategies, specifically things like conflict between the provisions of the 911 Good Samaritan law and efforts to reduce drug-induced homicide laws, to enforce drug-induced homicide laws. We also hear anecdotal reports of people who are using syringe access programs still being arrested for possessing syringes, even though they should be protected. So I think this is another place where we can think about gaps. which is where do the public health efforts and the criminal justice efforts bump heads, and where can we think about where they're not aligned with a common purpose? Thank you.
Thank you, Dr. Wagner. Elyse, I'll call on you next. Before I move to Elyse, I just wanted to mention that harm reduction perspective that Dr. Wagner brought up, instead of siloing it into two just strategies. I mean, I don't know what it would look like, but and for me, it kind of rolls into like something around or similar to stigma, but how do we instill this perspective within the whole of the healthcare system? Because it seems to be lacking all around, right? Like, how do we reduce the harm that we're causing as people with substance use disorders go into the healthcare system, and we ask them to tell their story, 10 times, or ask them, 5 times where they sleep last night, and they have to go through the shame and the hurt and the pain again of, I have a drug problem and I sleep outside, or I broke into a place, or whatever it may be. So again, it kind of ties into society-wide stigma type of thing when we talk about harm reduction as a perspective, and getting more of the healthcare system to kind of align with that ideology. Elyse, can you please share with us?
Yes, thank you. Elyse Monroy for the record. So I have a number of comments. I'm sure no one is surprised by that. But first, I'll say, when I was going through the report, I noticed a couple technical edits specific to attribution, I guess it would be related to where data is being pulled from and attributed to. So as an example, the report says that my program collects, or OD2A collects TEDS data. It absolutely does not collect TEDS data. I also had some questions about some of the Medicaid numbers. So there's just some technical edits. I will just go through the document and provide those back to staff. I just wanted to let everybody kind of know that I'd be doing that. Okay, so first, about the data, I just want to, I guess, kind of say for the record, I think we need to be really careful in our language when we're talking about needing data. I think that we oftentimes hear people say, we need data, but really what we need is thoughtful analytics, and we need someone to tell us what the data is, what it means. And that's not data, that's analysis and analytics. So when we talk even further about standardizing data collection, yes, for some, so OD maps is a good example of where data collection historically has not been standardized, which is where we have law enforcement agencies across jurisdictions not putting information into the system the same way. That's a standardization issue. But the way that it's presented in this document is you have a hospital system, a hospital data system, a coroner data system, a law enforcement data system. That collection is never going to be standardized because they're different systems that serve different purposes. So what I think we're trying to say is that we need to have standardized analysis or analytics to tell us what is causing harm and risk in the community. I also want to point out, and this goes along with analytics, so I'm shocked to hear that the PDMP data is not currently telling us co-prescribing information. That is what the PDMP is for. If it's not telling us that, it's because we're not asking the right question of the system, or we're not using the system in a way to tell us this answer. So in Nevada, historically, we have used the Prescription Drug Monitoring Program, which, for people who might not know, is a registry of all of the controlled substance prescriptions in the state. It's been historically used as a primary prevention tool, was noted in the needs assessment as a primary prevention tool, but in Nevada, it's been historically used as a regulatory and law enforcement tool. We shouldn't use it like that. We should use it to tell us about public health and to tell us about patient outcomes, but we have to start using it that way. I'll also say the state has a wealth of data from law enforcement that is currently living in their their law enforcement data systems and at forensic labs that does not inform public health strategies, and it should. So that's a really good example of, again, where we have data systems and data living places that's not being used or analyzed in a meaningful way. So only kind of two more quick questions or two more quick comments. This needs assessment was very, very prescription drug heavy. Prescription drugs are not currently fueling our deaths in Nevada. Fentanyl is fueling our deaths in Nevada. So I think that there needs to be more information in the needs assessment about like the illicit drug supply. Unfortunately, we don't have a lot of data about the illicit drug supply because we don't get that data. So it's really prescription drug heavy, but we know our problem is fentanyl. One of our problems is fentanyl. And then to Dr. Wagner's question about fatality review. There's definitely funding that needs to support fatality review, but in Nevada, fatality review is a policy question. So like, sometimes if you're someone that follows the legislative process, we have policy committees and we have money committees. And in money committees, you talk about making sure there's resources to implement policy and program. And in policy committees, you talk about the policy of a policy or a program. So I kind of see the ACRN and the Surge as being a money committee and a policy committee. And I think that it might be helpful maybe during the next meeting when the state comes and talks about like what expectations are, we could get some clarity around like the role of the ACRN in helping to point resources and the role of the Surge in outlaying policy. So that's kind of how I see them. And then the last thing I'll say is I am really glad to hear acknowledgement of not enough youth prevention being talked about in the needs assessment. I'm kind of surprised by that. We've had groups in Nevada working on youth prevention for decades in Nevada. I'm really surprised to see there wasn't more to pull from. I am at the National Prescription Drug Summit in Atlanta, and yesterday I attended a presentation from Virginia, their lessons learned from their first round of settlement dollar allocation, and their biggest lesson learned was that they did not invest in youth prevention in a meaningful way. So it would be a huge loss, I think, to the state, and we would we just need to make sure youth prevention is part of the needs assessment. So thank you for the time to make so many comments. Thanks, Chair.
Thank you, Elyse. Do we have anybody else that would like to comment on the presentation made by Mercer? Any questions?
Cornelia Sheehan, Mr. Chair, this is one of those times when the process discussion comes back up for me. There's so many areas. Elyse, you highlighted a number of them. Youth prevention, other things that were brought up in the report that if we were to dig in even right now, there were 5 or 6 that jumped out at me that I've worked closely with and could have discussions that were very productive with committee members familiar and actually moving toward sort of an identification of some of the resources and how we might, consider resourcing some of those agencies, persons, providers. So I just wanted to sort of highlight, bring back our process discussion from earlier and identify this would be one of those times when there's some actionable things here in terms of process. I hope that makes sense.
Yes, thank you so much, Cornelius. And after you said what you said, what it brings to mind for me is it almost seems like Mercer gives a presentation. Elyse sees something, you see something, and I have my thoughts, and I'm sure the rest of the committee has their thoughts. It's almost as if right now on the spot, we're supposed to bring to light these clarifications or these questions or these comments to Mercer. Mercer's supposed to bring something back to us. You know, the next meeting that we're hoping to have to kind of get some ideas on process and purpose, I wonder if in that same meeting we have Mercer there, and you can bring up your points, Elyse, or hopefully by then maybe Mercer will be able to look into what you brought up. And Cornelius, you mentioned that you can think of 5 that have to do with prevention right away, and maybe Mercer can bring something back about that. But for me, as I heard the presentation and as I heard you guys speak afterwards, the thing that comes to mind is sort of similar. You know, I heard a lot about gaps and about data and not having it, but also needing to keep in mind, you know, the disparities between different groups that may be included or can be assumed to be included. And I think that part of the process that I'm confused on or that we're having troubles with, maybe just saying, Mercer, my understanding is that now I'm blinking and got those nerves going, but that when we talk about some places that might be missing information or some communities that might be missing support is, you know, Spanish-speaking clients in inpatient facilities. You know, how many inpatient facilities do we have across the state, and how many of them are willing to take someone who speaks Spanish? I don't know. We could go on and on with a broad array of questions for Mercer to bring back to us, but I think part of the process confusion is, where do we say it was heavy on pain management or prescription parts, and there are some things that the committee would like to see more of and less of. Please, Dr. Cantrell.
So the way I see the report is that it's full, it's like a lot of gaps. The point of the report was to give enough gaps and data-based gaps in order to allow you guys to make recommendations that can get funded, right? Because that's kind of what the legislative purpose for the needs assessment was, to support that these recommendations are needed. I think if you look at the gaps, you could probably identify, I mean, that the fact that there are treatment disparities, it looks like there are treatment disparities among races, the fact that there's just not enough treatment, there's not enough in rural areas, you could put the recommendations you just talked about under any one of those gaps. So a broad gap of needing more mental health treatment should include more mental health treatment that also is culturally responsive and does accept people that speak other languages and things like that. So I think that if the committee, and this is just my very much outside thought, is that we've got the gaps. If there are additional gaps, let us know. But I don't, if there's something that seems like there are recommendations you need, but if we've got the gaps, that's the point to go ahead and start brainstorming all those recommendations. One thing you could do is divide into groups based on the way we grouped the gaps and have work groups come up with recommendations for each one as well. But that's just a thought. It's a lot of what you guys are talking about when you're saying these gaps are missing are actually recommendations that we can make. So kind of just flip it on its head and say, if you don't see this gap, think about the recommendation you would put in its place, and we can probably apply it under one of the gaps.
And so when we go back to process, right, it sounds like what I'm hearing from Dr. Cantrell is an opportunity. If there's something that someone on this committee feels is important and missing or needs more financial support from the state in our communities as far as treatment for people that have been affected by the opioid epidemic, whatever is presented by Mercer is then to be taken by us and said, because this is a gap, this is my recommendation. Because this is been presented by Mercer and we feel not enough funding is going towards that in our state, this is my recommendation to Mercer. So it almost seems that we can have Mercer continue looking up information, bringing us reports and data or experiences throughout the community, but we are the material experts. What am I trying to say? We're the people that have the connection to the community. So with what they have brought and with our experience, we should be getting close enough to the point to where we can present these recommendations. Does anyone, and I guess the confusion then would be at what part of the process and how do we have these collaborative conversations with each other to determine what our recommendations would be. Dr. Woodard?
Thank you, Chair. I just want to jump in real quick because I do hear the committee kind of grappling and really appreciate all of the conversation that has gone on today. But to sort of clarify where we are in the process, the goal is to develop the needs assessment. And as Dr. Cantrell just mentioned, that needs assessment resulting in gaps to assist in identifying recommendations. The role of this committee is to actually establish a report for the director's office on recommendations. And those recommendations will then have priorities so that we recognize where the recommendations are and then where the priorities of those recommendations are that can then be used in the development of the state plan. And the state plan is where the director's office will then use the state plan to allocate funds based on the prioritized recommendations. So really the goal of this group is to do exactly what you're doing right now. Bring ideas forward as to what those recommendations are. We've got staff that are on this call that will be taking, dubious notes in minutes. We will then be able to bring these recommendations back to the committee for further discussion and to solidify and finalize those recommendations so they can be added into a report that will be going to the director's office that will then be used to guide the establishment of the state plan. That report is actually due every other year on even number years in subsequent years for the ACRN. This year is different because this is the first time we're doing the needs assessment. This is the first time that we will be doing recommendations and the first time that we are developing the state plan. So the cadence is a little off this time because we're really trying to move forward and get the process going so that we can have a state plan to allocate the funds so that we can be responsive to the community needs. So I just wanted to add that in because that is really the role of the ACRN is to develop that report with recommendations and priorities and then also recommendations for the state plan.
Thank you, Dr. Woodard. So would you say that we should keep going from where we're at now and just have this open conversation and say, if you have thoughts about what you would like to see done in our community as these opioid dollars are being dispensed as a panelist, now is the time to do it?
Yes, absolutely. This is exactly where we need to be in the process. Now, if there needs to be an additional meeting so that people can also have some time and distance to be able to re-review the needs assessment, to contemplate the known gaps, and to also develop additional recommendations for further discussion. And it sounded like that was being contemplated is to use the next meeting to actually solidify those recommendations. Then this committee will be in a place to be able to finalize those recommendations, to be put into a report, to be then submitted to the director's office. With prioritization of those recommendations. It is from that the state plan will be developed. And so this work is actually really important work for the committee to do and is really one of the core functions of the committee as a whole.
Okay, thank you so much, Dr. Woodard. Elyse, I'll call on you and then I'll call on Cornelius. Before I call on you, Elyse, I'd just like to say that my part or the piece that I see that I'd like to have our committee take into mind is just an army of peer support workers and community health workers implemented in all these recovery fields to kind of do that wraparound services, the before, the after, the getting connected to other services, whether it be, primary care doctor that isn't involved with medicated assistant treatment, but just is, taking care of their well-being, and that peer support to help people navigate recovery between outpatient services as their outpatient services get lessened, and specifically targeting the people that are not just connected to recovery treatment services because of the judicial system. Elyse.
Thank you, Chair. So Dr. Woodard, I think I have then a technical process question. So where then are we supposed to use the health equity toolkit method? Like, are we supposed to be doing that now or next week? Like, what's the, so when are we supposed to do that?
So the health equity lens that's been developed is really a guide for this group to include in your considerations, discussions, thought processes of how the recommendations really could be utilized to address things like health equity. I think it's important for people to be using this as really a way to consider multiple factors in the decisions of this group, but it's also for individual committee members to use in their consideration of the gaps and recommendations.
Okay, thank you.
Thank you, Elyse. Thank you, Dr. Woodard. I have Courtney. Elyse, did you still have your hand up, or you? You're on mute. Cornelius, you're on mute.
I'm so sorry.
It's okay.
I'm so used to it because my dogs are barking in the background. Pardon me. So I hope that's not a distraction. I just wanted to say that that was very clarifying as far as process went, and I could see digging right into these things. I do feel the urgency that a lot of people express with some of these gaps identified, but I think this moves us forward. I would need a little time to digest what we saw and digest some of the discussion points before being able to jump into conversation. So while I'd want to do that contemporaneously with Ms. Cantrell's presentation, I would need a little time to digest and then break off and consider. One final thing, just while I'm on right now, there are comments from members of the public popping up in chat, and I'm feeling a responsibility as a committee member to acknowledge those, but it's not a part of the public conversation time. So I'm confused on a process level what we do about chat comments that come in during the process from members of the public. And again, thank you for your patience with me. I'm new to this type of process. So if somebody could help me there, I'd appreciate that. A procedural question, I guess, if that makes sense.
Yes, thank you, Cornelius. I'm also on the same page because it's not the public comment section of the meeting. I didn't really know what my responsibility is to read the comments out loud or just acknowledge them.
This is Henna, Senior Deputy Attorney General. Typically with meetings where the chat function is allowed to be on, public comments don't have to be acknowledged during the meeting. They will become part of the minutes because the committee is required to attach. If they're going to leave the chat function on, then everything that is in the chat would be required to be attached to the minutes. But you don't necessarily have to address any of the comments. That's up to you. But the public should be made aware of that. There will be a time provided for public comment vocally, and that's at the end of the meeting. And also, I believe during this agenda item, after the committee makes their comments.
Thank you, Ms. Rasul. Dr. Woodard, do you have your hand up?
Thank you, Chair. It was a comment for earlier, so I'll put it back down, and if the conversation comes back around that way, I'll raise it again.
Thank you. And again, thank you for the clarification, Ms. Rasul and Cornelius. Good job on bringing that up. I'm reading them as they're coming in, and for me, it's just waiting until we get to the next public comment section and saying, is there anyone for public comment? If you wrote in the comments, now's your time to speak, but we'll continue where we're at. And I'll ask again, does anyone on the committee panelist have anything that they'd like to add to what we talked about so far? Again, everything that we're talking about or everything that we're bringing up that matters and is important to us, as we receive these reports from Mercer, it's important that they hear back from us, whether it's just something about their presentation or something that we feel needs to be addressed as we move forward and make these recommendations. Dr. Wagner?
Thank you, Chair. Just a follow-up to what I was saying earlier about the racial disparities in treatment access. I found the bit in the report that refers to that, and I would actually like to see a more detailed analysis of that. And I think this actually speaks to Elyse's comment earlier. So it's on page 13 of the draft that I'm looking at, and it says that the TEDS data set maintained by ODTA found that minority adults are also less likely to seek treatment when compared to white adults. So as Elyse pointed out, ODTA doesn't have TEDS data, and I would like to know whether that was just, I would like to know how that comparison was done and look a little bit more closely at those data, because just looking at the demographic distribution of treatment seeking people doesn't tell us about the need. So I would like to know if those folks, if there's some comparison there about people who actually need treatment versus those who are getting it.
Thank you, Dr. Wagner. And
Or
my
want
understanding,
treatment and are getting it.
right. And my understanding, I'm not sure about the background of the information provided by Mercer, but my understanding is that it sounds pretty true to alignment of what my experience has been, is that it generally the people seeking treatment and getting treatment are Caucasian, and the people that in comparison, there's a similar number to people that are minorities that would like to access treatment but are not getting treatment. And I don't know the how or the why, but I guess I would just say that my understanding aligns with what Mercer brought.
Yep. Yeah, I think you're quite right, but I also think we need some sort of indicator of unmet treatment need. And I also think it would be helpful for us to understand what is defined as treatment, because we also know that there are racial differences in who's using what drugs and what treatment is available for different drug types. So for example, if there are racial differences in the use of opioids versus stimulants, there's not as many evidence-based treatments for stimulants. And so you might be, we might be seeing patterns that tell us a lot more about unmet need than we can distill just from this data point. And I would like to know those things to speak to exactly what you're saying.
Thank you, Dr. Wagner. And one thing that keeps crossing my mind as I've heard the presentation and we've talked is that, when we're making these recommendations and it revolves around the opioid epidemic, how moral or rational is it to group people that use drugs and people that use only opioids into what we should be targeting? My personal experience and my understanding is that people who use opioids probably use other drugs. So does that mean we're fine, comfortable with targeting the whole of people that use substances, or with a forethought of of course opioids should be the head of this sphere, but just substance use recovery supports as a whole. Does that make sense?
Can I have this is Carla Wagner again, just to follow up. I think you are exactly right. I think this is the data suggests that the majority of people are polysubstance users. It is not, I don't think it's realistic to think that there is a group of people out there who are only using opioids in the absence of other substances, and that they need different things than people who are using polysubstances, because as you say, and the death data are a little bit misleading sometimes this way, because we often categorize deaths, for example, as opioid related or stimulant related, but most deaths are polysubstance use related. So you're quite right.
Thank you, Dr. Wagner. Would anybody like to speak as part of the panel that has not voiced their opinion or their thoughts on what we've talked about so far or what has been presented? I have Laura.
Thank you, Chair. In public comment, we heard reference made to the 2017 Johns Hopkins document, which is our guidance to the states. And we're aware that there is a 2021 version. So I would like to make a recommendation that we are following the 2021 version. Obviously, a lot has changed in our state from 2017.
Thank you, Laura. Dr. Cantrell.
Yeah, so what we had used was not just the Johns Hopkins paper, but a presentation and a paper where the Johns Hopkins information was put up against what's going on in Nevada right now. So I'll have to talk with staff and see if there is a 2021 report that actually has the Johns Hopkins requirements along with, because that was something that I think was maybe Elyse that was given at the opioid response.
Yeah, so this is Elyse. So that was something that my program, the OD2A program, did a year ago. I would bet if someone could just take a look at the most recent Johns Hopkins report that's being referenced, there's not going to be a big difference. So you can probably do a little bit of like smooshing, which is a technical term I use, smooshing together of reports to help with that.
Right. So we didn't go grab the 2017 report. We were going based on presentations that were specific to Nevada for that report, or Nevada for that report. So,
yeah, and I think our program put that together. Oh, crud. It was 2021 we did that. So the Johns Hopkins report probably was just out very recently. So it probably hadn't come across, the new Johns Hopkins report probably hadn't come across our radar yet, would be probably what happened.
This is Carla Wagner again, for the record. I just, to the chair's earlier point about polysubstance use, I suspect that a newer report will have a lot more to say about the role of polysubstance use and the involvement of stimulants in the kind of current phase of the national drug use epidemic that we're experiencing.
Thank you. I don't see anyone else from the committee interested in speaking on this agenda item. At this point, if there's no further comment or question for Mercer or in regards to the general conversation that we've been having over the last little bit, I'd like to move us to the next agenda item. At this point, I guess we're kind of ready. Sorry. Agenda item number 6, public input on final draft needs assessment. This is your opportunity, those that have been commenting in the chat, to solicit comments from the public concerning recommendations. I'm going to go to the chat, and those that said that they would like to provide comment, I will call on you. If you just bear with me a moment so I can work through these comments to find someone to call on. Just one moment, please. I believe I'm going to start with Mike Fuller. Mike Fuller, are you available for public? Is this, am I good on the on this part of the agenda? Because I have public input and then I have public comment number 2. Ms. Rasul, can you correct me if I'm wrong?
I'm sorry, can you repeat that?
I just want to make sure that I'm all right and giving the public an opportunity to speak at this time. I'm on agenda item number 6, where I have public input on final draft needs assessment, and I'm not on public comment number 2, but I want to make sure that it's okay that I invite the public.
Oh, absolutely. Yeah,
Okay.
yeah, because it's provided for in that agenda item, yes.
Okay, thank you. Mike Fuller, are you available for comment?
Yes, I'm here.
Go ahead.
Good to see you, David. I haven't seen you in a long time.
Good to see you.
I've got several things to say, if you don't mind. I know I got a short period of time. You know, as far as the NAMI presentation, you know, I would like to see more clarity on what her scales is with with what she's asking for, because I think that would give a better understanding. I've been in this field for a very long time. I've worked with co-occurring disorders, poly abusers, opiate users, you know, just basically all of it. I've done, you know, multiple different tasks. I've worked on coalition teams, developing coalition teams all through Northern Nevada. And, you know, but the key points I want to talk about for a second is the needs assessment that the Mercer presented. I like the way that they were done with the broad gaps that were there, but yet at the same time, the way that they can be closed down, you know, that it's up to the recommendation of the committee to close those gaps, because it gives you a little bit of a broad spectrum to where you can close the gap. And you know, I can see where you would take each one with the recommendation that you're making with that gap that is there, because they're not all the same. Because if you generalize it as for everything on a general thing, then that's not being fair to each agency or each organization that's coming in asking the committee for assistance in their program. And I want to thank that one, I believe it's Dr. Woodard, for giving me a really good, clear understanding of what this committee is about. Because prior to that, I was seeing in my mind a lot of dysfunction, but now I have a better understanding of it. And I did ask to be a member of this committee back in the latter part of September, because I had lost the information prior to in July. That's all I have. Thanks.
Thank you, Mr. Fuller. The next person that I would like to call on is Linda Lang. Linda?
Thank you, Chair Sanchez. I hope you can hear me.
Yes, again.
Perfect. Thank you so much for the PowerPoint that was given today. First of all, my name is Linda Lang, and I'm with the Nevada Statewide Coalition Partnership. It's a collaboration of all the community coalitions that address primarily substance misuse and mental health and wellness in the state. I want to thank you for the PowerPoint presentation today, because it actually included a lot of things that were not clear to me in the actual needs assessment. So I hope that becomes part of you know, the full document of this meeting, because it was a lot clearer than the needs assessment to me, at least. And I want to address right now specific to pages 5 and 6 and prevention. I want to state that the gaps are definitely correct and that more is needed to support education and stigma in the state of Nevada. The recommendations are good. The positive thing is that there is a strong system already in place in the state of Nevada to move forward strategies that already exist, or maybe new strategies that are currently lacking due to funding. These recommendations, many of them on page 5 and 6, and also the harm reduction, could be activated fairly quickly, so we can affect change sooner rather than later among our citizens. I do want to address that missing throughout this entire process has been the inclusion of secondary prevention. This can also be termed intervention. This is a huge gap in Nevada, and it has been for over a decade. The main reason for the gap is there is no federal funding or state funding that will specifically address secondary prevention and intervention. With our youth being in crisis right now, we need to support the secondary prevention, possibly as much as the primary prevention. This includes things such as brief screenings, drug testings, mental health assessments. All of these things occur prior to people being diagnosed with a substance use disorder, and it's where we need to focus our efforts now in the state of Nevada. Finally, related to the overall prevention, youth, young adults, and the aging across the board, one system that is already in place was put into legislation during the 2021 session through SB 69. There are 3 sections of the 4 in the bill that relate specifically to prevention. 1 relates to YRBS data collection. 2 relates to evidence-based programming in our schools. And the 3rd relates to formalizing and recognizing the coalition model in Nevada. Specifically, it states in the actual bill under section 2, number 3, the division shall collaborate with and utilize certified substance use disorder prevention coalitions as the primary local and regional entities to collaborate programs and strategies for the prevention of substance use disorders in the state. And that is legislated in SB 69. And then there's a definition I won't read right now about what the coalition actually definition is. And finally, it also is in NAC 458 that those that work in the field of prevention in the state have to be certified. And this is an important note for those that are making recommendations through the ACRN, because not only do coalitions have to be certified, but anybody providing primary prevention in the state, administratively or directly, have to be certified. So those are my public comments, and thank you very much.
Thank you, Linda. Great points there. I really appreciate the intervention, secondary prevention points. And the next person I would like to call on for public comment is in regards to the needs assessment is Katie Zeller. Katie, I have you on and unmuted, but I cannot hear you.
Can you hear me now?
Yep, I gotcha.
Perfect. Thank you. I was talking away. Good morning, and I'd like to echo just a little bit of what Linda Lang said. My name is Katie Zeller, and I'm the project coordinator for Churchill Community Coalition. So there were many prevention gaps identified in the needs assessment and report. And I'd like to mention that all of the SAPTA certified prevention coalitions currently address a large percentage of these gaps that wasn't, and our information wasn't included. Something that I'd like to highlight and that we're really proud of in the Mercer report, Northern Nevada drug-related deaths increased 27%, and overdose deaths attributed to opioids increased by 28%. And in consideration for Churchill County, drug-related overdose deaths decreased 4%, and opioid-related overdose decreased 3.9%. The Churchill Coalition makes coordinated efforts with law enforcement, hospitals, pharmacies, treatment centers, behavioral health centers, school administration, tribal agencies, and other key stakeholders to ensure the implementation of opioid and other drug use prevention programs are effective and benefiting our community. And this includes projects like our RX Take Back Days, drop boxes, behavioral health task force meetings, youth and juvenile and family prevention programs, drug monitoring programs, data collection, and community education forums. And just to kind of echo that, it's essential to involve all substance use coalitions in the conversation and to continue to look at our current prevention efforts that may help fill those gaps, as stated in as Linda stated, Senate Bill 69 and the NRS 458. So that's my piece for the coalition. The other thing I would like to mention is in addressing the equity piece for tribal communities. I understand there has been an attempt to address the equity gaps through the Nevada Minority Health and Equity Coalition efforts. But we do know that their time frame was limited, and there seems to be no other efforts that we have seen explicitly for tribal involvement. And I know personally, as a Native American person, that tribal health clinics do have behavioral health and peer specialists that can help supplement that data and where those gaps seem to be in that needs assessment. So maybe reaching out to some of them and making sure that our tribal entities are not only included in surveys, but also giving insight for the future. Thank you.
Thank you, Katie. Great points. Appreciate you speaking up. I have a public comment from Sarah Adler that has been written, but it doesn't look like she wants to speak. That looks like all we have right now for public comment. I don't see anybody else in the chat that mentioned that they would like to speak and add a public comment on the needs assessment. So for this agenda item number 6, I will end this portion and we will move to agenda item number 7. Yeah, please.
Cornelia Sheen, it looks like Catrice Saunders has had a hand raised through public comment.
Catrice,
I'm not sure if you saw that.
Thank you. Catrice, did you want to speak on the needs assessment in public comment?
No, I already gave my input and then I'll be forwarding over my recommendations as well. I just wanted to share my story with all those unfamiliar of what I've been through in the state of Nevada at a state level, also at a federal level, helping make millions of dollars for local business owners and somehow still being left out, still having to advocate and take care of my mental health, my children's mental health, all out of my own pocket. Has been really stressful. Growing up in the state of Nevada, from the time I was a child, going to preschool, elementary, junior high school, and college, and then having made millions of dollars, probably for the travel industry as well. I'm just tired of having my voice kind of be drowned out when I'm trying to advocate for real change, because I've had to deal with things on a socio-economic level that most people probably don't have the voice to speak up because they're still traumatized, but I have a right to my children and my grandchildren to right the wrongs that have been done to me and so many others in the state of Nevada. So I would just like to be more involved on actually making an impact and not just talking about it. And I wanted to know also when the funds are going to be allocated so we can start to repair some of the harms and I can get back to living a normal, decent life for me and my family. Thank you for your time today.
Thank you, Katrine. I don't know if we have any specific answers for Katrine's public comment on agenda item number 6, but we appreciate the community being involved and giving us their perspective and their experiences as we move through this information in these committee meetings. So thank you for showing up today and thank you for speaking. Again, I will move to agenda item number 7. Looks like we have nobody else looking to speak for public comment on the topic of the needs assessment. Agenda item number 7 refers to the notice of the next date for the next ACRN meeting to be held on May 18th, 2022 at 9 a.m. I believe we got some save the date reminders for this next meeting, and our state facilitators, Joan and Don, will set out the invitations for our next meeting when they can. Again, I don't know if we need to cover it, but just have a discussion that at this next meeting on May 18th, we're going to ask that the Dawn and her team bring a little bit of clarification to the committee and also open the meeting up so that the committee members can ask any questions about process and maybe give some input on what we've heard so far and just get a better idea of how we come to the recommendations that we're going to be giving to the state. Does that sound accurate to everyone? Dr. Woodard?
Thank you, David. This is Dawn, just real quick. We will also have Terry Kerns from the Attorney General's office be able to come and give a presentation as well regarding the surge. So that will also be on the agenda. Perfect. And Dr. Woodard, your hand was up.
Yes, good afternoon, Chair and Committee. Thinking about the agenda for the next meeting and thinking about the process and potentially support for facilitation of some of the discussion and finalization for some of the recommendations, just wanted to suggest that there were some recommendations that were heard today. Staff will be working to identify those recommendations to be able to bring forward to this committee for consideration. I think part of the goal of the next meeting really is to continue to bring forward some of those recommendations for discussion and finalization to be used in prioritization. So to support that effort, I also wanted to just recognize that Mercer has presented in previous meetings on a matrix that they have developed to help to identify areas of priority. And so having the recommendations for this from this committee will be vitally important for that process. So if there's anything that we may be able to do to help to facilitate the conversation in the next meeting, we're more than happy to do that if that is the committee and the chair's wish. In addition to that, if it would be helpful to collect information from committee members prior to the next meeting so that we as staff can help to organize those recommendations to help to further facilitate that discussion. We are more than happy to do that as well. So just wanted to put those out there as suggestions and offers to make sure that we are providing the necessary support for this committee to do its important work.
Thank you so much, Dr. Woodard. And so what I'm hearing is, and help me if I'm confused, but it almost sounds like we could be at a point where we send the committee members an email that says, you know, with what we have, with the information we have so far, what are your top 9 priorities towards funding? And then we meet and we talk about what each one of us sent back and kind of go from there. Does that sound kind of similar to what we're talking about?
I think the goal would be to use this interim time while the committee has time to go back in to review the needs assessment, to review the gaps, the presentation that was provided today, to be able to help to solidify some additional recommendations for this committee to be able to consider. We can certainly develop a survey or a spreadsheet or something to be able to collect important information from this committee that we could then bring back to the entire committee body for a presentation in support to facilitate discussion to solidify those recommendations.
Thank you, Dr. Woodard. And, you know, committee and just speaking for myself, and I believe portions of the committee, there's information that we don't have. There's information that we could use more of. There's clarifications that Mercer could bring to us. But we do have a sort of a sense of what has been presented so far. So planning that we get some gaps filled in and get some more information, some more data, I think it wouldn't hurt for us to give kind of a sense of where we stand today without having the complete picture that we're looking for. And then we get more information and we kind of realign what we're looking at. Does that sound reasonable to everyone? Is the committee comfortable with receiving sort of a survey or sort of a questionnaire or something to help facilitate us get into the conversation of recommendations for our next meeting in between this meeting and the next? Cornelius?
Cornelius Sheehan, that sounds great to me, Mr. Chair. And also, I think it'll give us an opportunity to hear from committee members who've not been in attendance for some of the community that represent important parts of the community, would have an important voice. I'm thinking, and forgive me if these folks have been in attendance and I just haven't noticed, but like from the school district, for example, I don't recall having heard from folks from the school district. So I think that process would be really helpful.
And this is Elyse, Chair, if I could.
Please.
I agree that a survey would be helpful. I guess I would just want to make sure that if a survey is being used as a way for committee members to solicit or like for us to provide feedback, that there be like free text fields. I'm not sure what that would look like, but just to make sure if whatever check boxes aren't there for me to check, I can write whatever I have to say. So just for consideration of staff. Thank you.
Thank you. Dr. Woodard?
Yeah, so thank you, Chair. To Elise's point, not a survey where it's just a forced answer, but to be able to have the committee members have just a structured way to provide information. Just thinking through some of this, likely identify what the gap is, identify what the recommendation is related to the gap, and then potentially connect it to the identified areas that are in the legislation that have already been identified for potential funding, recognizing that that is not a finite list, and there may be other areas that are not already defined in the legislation. Just trying to think of ways that we may, as staff, be able to support the committee in really providing some structure to help this committee ultimately develop the finalized recommendations for a report.
Beautiful. Thank you so much, Dr. Woodard. I think that's exactly what we've been talking about. Some help facilitating conversation, moving forward, gaining a better understanding, and then producing some recommendations. And this will definitely hopefully give us a leg forward as we move towards that. Okay, so we have the next meeting set and we are finished with agenda item number 7. I'm gonna check and make sure I'm not missing anybody. Cornelius?
If I may, just really briefly, Cornelius Sheehan, for the record, you had commented earlier at some point, just kind of in passing, about your leadership. I don't have a personal relationship with you, but I just wanted to express my appreciation for the way you've led the committee, chaired the committee. I think you're doing an excellent job. I think you bring an openness to it that is necessary. When you bring this many folks with different stakeholders together to have this kind of discussion, it takes, I think, the kind of openness, humility that you're bringing to the process. So I want to thank you for that and recognize you.
Thank you, Cornelius. I appreciate it. And yeah, this is my first group of this type, and I just I'm doing the best I can, and I just want to represent well, and I just want to show up as best I can. And really, as I look at the committee, I just want to give people a chance to voice what they need to say and to feel comfortable to present their experience and to help guide. So I really would ask that more of the committee take the time to let go of that uneasiness and share with us your concerns, your struggles, your points that you stand on that are part of who you are. So just if we could get more people to speak and say what they need to say, I would advocate for that as much as possible. And I'm also looking for support, because again, this is my first time doing something like this, and being a chair of a committee of this nature. And so I would just ask that if you see me struggling somewhere or confused or forgetting something, I would welcome you and open it to please give me some pointers, a little nudge, a direction. I think that we should work together as what we are. We're people that are working in the helping fields, trying to help our communities and support as best we can. So just I could use any support just like anybody else. Thank you. Dr. Woodard?
Thank you, Chair. Just listening to some of the conversation during the meeting today and some of the challenges with especially meeting virtually and trying to engage collectively with one another. It's come up in several of these meetings. And just wanted to also offer, we do have the ability to provide in-person locations. If the committee wanted to be able to convene in person in both potentially a northern and a southern location. So that is something that we can certainly support and facilitate. I know just for myself, being on similar committees, qualitatively, there's just a very big difference when you're actually able to be physically present in a room, especially when you're doing some very important work that depends a lot on sort of presence and open dialogue and participation. So just wanted to bring that to your attention and the committee's attention, that we do have some flexibility to be able to provide in-person meeting support as well.
Thank you, Dr. Woodard. And as you were saying that, it kind of brought to light this feeling that I've been having as we've been having these meetings, is that if we were in person, it's almost like I could look over at Dr. Kamyar and say, and give him a head nod and say, what's your 2 cents on this issue? And I wonder if I should be doing something similar virtually, you know? And I don't want to call people out or put them on the, you know, up in front of everyone when they don't want to be, but I wish there was a way to virtually nod and say, what do you think about what was said over this time? And I'm not saying that we should require everybody to put in their 2 cents, but I would just, again, advocate to hear your point of view on these conversations as we move forward. If you have had limited opportunity to speak or just been nervous about voicing your opinion. And that's something that we should consider and could consider if there's anybody that is interested in meeting in person. And like Dr. Woodard said, if we're in the north, we'll meet in the north, and if we're in the south, we'll meet in the south, and then connect those 2 virtually. That is something that we could look into. I know for me, I get where Dr. Woodard is coming from, the personableness that we could have with each other if we were meeting in person. But at the same time, the scheduling and the time and effort it takes to show up virtually while we're in 2 different parts of the state may make that a challenge. So something to keep in mind. And I guess I would close with, if you're interested in meeting in person, please send Dawn or Joan an email just stating where you stand on that, and if you'd like to, where you're at and what that would look like for you. And if we get a bunch of people that have reached out to our facilitators that would like to meet in person, then we can make something happen. All right, moving from agenda item number 7 to agenda item number 8, I will open it again one more time for public comment. This time, public comment is not directly speaking to the needs assessment, more is just an opportunity for the public to make a comment that the committee can take into consideration. Please remember that we'd like to ask you to avoid repetition and limit your comments to no more than 3 minutes, and that we can't make any actionable items based off of public comment at this point. Is there anybody that wishes to speak for public comment at this time? I have Kate Kaplan with her hand up, and you are unmuted, Kate.
Thank you kindly. First of all, I do have to I have to commend every single one of the individuals who are participating here, because as an insider who's an outsider, I've never been to one of these public forums in this way. Let me say this: if we all were in the Ukraine, Zelensky would be in a world of trouble, because there just doesn't seem to be a plan when we all know that we're at war. And that does not take away from the contributions and the abilities and the heart that we all bring to this. I mean, I don't have the answers, or I wouldn't be here, right? But I do have questions. I've lived in this state all of my life, 73 years, and I do want to know. And I've seen monies come in and go out, and promises made, and marijuana money going to schools, and on and on and on. And I know you can't address that here, but we've got a lot of money on the line. And there's a lot of questions I have that I would love to have on public record. First of all, we have organizations and individuals throughout the state who have been working for years and years and years in this community and have proven their worth. Why aren't they just given some money to operate off of, instead of continuing to go around and paying for themselves or begging individuals? That used to be back in the day, you walk in, somebody gives you a brown paper bag and you go and take care of your business. But now you have committees and you have to do what you do, and on and on. You can't get any good work done. God bless you. I mean, I was listening to that poor lady, not poor lady, she's a great lady. She amount of information, but you send me this and then we'll put it in a report, and we meet every 2 years, and then that report will result in some suggestions that. And so the other thing I have to question is, I understand that Aaron Ford has promised to bring this lawsuit in behalf of the victims, and yet no monies have been dispersed to assist those who are no longer with us and those who were there with them when they couldn't be. And I want to know publicly if his law firm has collected, or his former law firm has collected the 19% that they were told they would be given for handling this. I want to know if it's been paid to them. And I want to know why that percentage is higher than in any other state. In fact, California, the people aren't taking anything at all. Because in my comments earlier, it's never about the money. Our kids are dying, and it's always about the money. Where is it? In 2019, the governor mandated that we would have mental health care in all of the schools, K through 12. Where is it? I don't see it. I have great grandchildren in school. God bless me. I don't see it. Where is it? Where's the money? And of course, I understand that so many other things have taken place, but if y'all don't think we are in a war for the next generation of these children, for our children, it's genocide out there, guys. I mean, we have to get serious about it without getting emotional and all of that. Let's make some things happen. We already have people in place who have lost loved ones, who give up hours and weeks and hundreds of thousands of dollars just to save the next kid. Where are these people? I know they exist. Why aren't they receiving money straight away? An assessment. Zelensky's going to do an assessment in the Ukraine. The Russians are killing us. Hello. So that's all. I guess it's the first time ever here watching something like this and understanding that everyone has the best of intentions, but good Lord. Anyway, I'm out there pounding the streets, and I hope everyone just pays attention to the fact that there is there's a killer out there, and it's really taking advantage of our young people. And I thank you all very much for listening to my rant. It was great fun, actually. I think it's good therapy. And I thank you to the doctors who were on as well. And that's me done.
Thank you. Thank you for your public comment. Do I have anyone else for public comment?
Chair, this is Dawn. I just wanted to go on record letting you know that we have received some public comment in regards to the needs assessment via email, and we will go ahead and again create an exhibit for all of those documents, send them out to the this body with all of the minutes.
Great. Thank you so much for that, Dawn. I appreciate it. Looks like we are concluded with public comment number 2, agenda item number 8, and we will move to agenda item number 9, which is adjournment. Thank you for meeting with us today. Thank you for taking the time to be a part of this committee, and let's keep it going. Thank you so much for your time, and have a great day. We'll see you on the 18th.
Thank you.
Take care.